Thanks for being so prompt, everyone. Hope you had a little bit of lunch because we're going to have a lot to discuss and you'll need your energy. We have an astounding panel in front of you. In addition to our esteemed panel members from CTAF, we have a variety of clinical experts whose names and positions are represented up on the slide. We'll be asking all of them to talk about clinically related issues, perhaps going beyond the scope of the evidence review and delving into some of the questions that we started talking about at the end of this morning. So my approach is going to be an active facilitator because we have a lot of people here and I want to make sure we get everybody's point of view. Now, I'm going to take the role kind of like a baseball umpire. I'm going to take some issues and throw them up here and see who touches them first, and then we'll go with it. I'll try to then moderate the input into that and change topics when we seem to have exhausted the first one. So I'm armed with many questions, and I'm prepared to go ahead and start throwing them out there unless one of our panel members would like to build on some of the questions we started on this morning from the clinical side of things and start there. So I'll ask our panel. You get first dibs. I know you're still chewing. Well, in that case, I'm going to go ahead and ask a clinical question that I'm a little unclear on. That is SVR12. We heard Jeff talk about whether or not SVR12 can be considered a cure. And I'd like our clinical experts to talk a little bit more about whether that truly represents a cure and whether an SVR at fibrosis stage 0 means the same thing or has the same implications for follow-up of patients as an SVR at stage F4. So if that question is enough to get us started, play ball. Who would like to start?
Well, an SVR, is this on? An SVR is a cure of the virus, but it is not a cure of the fibrosis that has taken place in the liver. So we can expect that there is a good chance that there will be fibrosis regression or stability that wouldn't have happened necessarily if the virus were still there. But the ongoing inflammation or additional scarring in the liver would be halted or even improve. So an SVR is referred to by some people as a cure. I think if you wanted to be more technical, you could call it clearance of the virus.
Others? Juan Carlos?
The reason why we choose, in this case, SVR, is actually because of the definition between acute viral infection and chronic viral infection. As you know, the definition for a chronic viral infection is when the virus is in your body more than 6 months. So that's why we chose the definition of SVR. So that's the starting point. Then we move into the development of, in this case, different treatments for hepatitis C. And we chose in that time SVR for interferon. That worked very well, SVR being SVR 24 always. And the reason for that later with the follow-up is we saw that more than 98% of the patients, when they were followed up more than 10 years, 15 years, they were still negative. So the correlation with virological cure was very strong. Now with these antivirals we have in development, it has been a convenience to move it from 24 into 12, just because the correlation is also very strong between 12 and 24. But I think we cannot be misled because the SVR at week 4 and 12, as you said before, is very high, but different regimens, the relapse between 12 and 24 are also different too. Small percentage, 2, 3, 5%, but it's a substantial number, right? Still, SVR 24 is the one that defines that the virus is not there, and is the one that correlates with long term.
Bill?
So I'll speak to the data for Sovaldi. We've looked at SVR4, SVR12, and SVR24, and actually even SVR72, because we have patients enrolled into our trials out to 5 years. So SVR4 to SVR12, the concordance was about 98%, but then SVR12 to 24 was 100%, and SVR24 to 72 was 100%. And so we've got data out for Sovaldi out to 72 weeks post-viral clearance. We are going to follow them longer, out again 5 years to follow that up, and also to follow, maybe back to Rena's comment, to see if we do see this regression in fibrosis and cirrhosis, because we've been able to see that in hepatitis B, but we'll have to prove can we do that in hepatitis C. And then for cephosphorylate liposphere, we followed up SVR 12 to 24, and we've presented that there's 100% concordance between SVR 12 and 24. We'll keep evaluating that as well out 5 years.
So I want to press this just a little bit more to make sure we all understand it, which is that SVR 12 is eradication of the virus with sometime, small per numbers, reappearance of the virus over time. Rena made the point that there's eradication of the virus and there's cure of the disease, so what's actually happening in the liver, extrahepatic, all those sorts of things. So is an SVR an SVR at F0, at F4, from one drug regimen versus another drug regimen? Do we know anything about what SVRs mean under those different conditions?
Well, my understanding with some combinations is that there is relapse post SVR 12. Sofosbuvir and cimipravir have some relapse incidence. I don't know what the percentage is. I don't have numbers. But SVR 24 sounds safer.
Any other comments? Perhaps I'm asking something which is not really known yet, so we'll come back to that perhaps. Joanna, did you want to comment?
Well, no, just that we know that it's harder to get an SVR of any kind the higher the fibrosis rate. But once you get the SVR, we think an SVR is an SVR. You just have a lower SVR the higher your F score.
Yeah, I would agree with that. We've even seen that in our data, that F0 to F3, similar response rates. F4, it may either take a longer duration. I mean, look at our indication for treatment-experienced cirrhotics. We have a 24-week indication. We're going to try to change that with data from ASLD, but it shows that you need a longer duration or the addition of ribavirin. And so we have seen differencing in response rates.
The reason I was pressing this a little bit is to ask the clinicians again, what are the appropriate follow-up protocols for patients who've achieved SVR, either with one regimen versus another or at one fibrosis stage versus another? Any comments there?
There are two approaches, Jeff. One is the patient who achieved SVR should be followed. And if the patient has already fibrosis, even more reason to be followed up long term. And the reason for that is one thing, as Rena mentioned, is the cure of the virus. But the damage that was induced to the liver, any kind of fibrosis, is already a trigger for any future complications, hopefully will be reduced. But we need to follow up these patients for the prevention of any kind of complication like liver cancer, for instance, right? So a patient cured from the virus doesn't mean that we should abandon that patient forever. I think still we don't know enough. We should be following that patient yearly at least and see how it goes. And we don't have enough data in terms of long-term with interferon-free regimens. If an SVR in cirrhotics, for instance, is not going to relapse years later, we assume, and we think that is not going to happen. We have that data with PEG interferon-based therapy, that patients with cirrhosis, once they achieve SVR, has been SVR.
Rena, did you have a comment?
I agree. I mean, you're going to follow your patient depending on the degree of liver disease that they have. So if the patient is cirrhotic, even if you cure their virus, they still need appropriate treatment and follow-up as a cirrhotic patient. I just want to add one other thing to your idea, though, about is an SVR at any fibrosis stage. We also treat patients with acute infection who have no liver disease yet at all in the first 6 months after having been infected. There's some trials going on right now with the DAAs on acute infection, but in terms of the best data that's been out there, it's on PEG interferon, even standard interferon with and without ribavirin, and they have very high SVR rates, and patients do not go on to get liver disease.
That's remarkable. And Rena brings up the clinical entity of acute viral hepatitis C, which is fair game for this discussion, even though that wasn't within scope for our clinical review. So if there are other kinds of clinical situations, don't be afraid to bring them up. Okay, so monitoring for hepatocellular carcinoma might still go on for patients who have established cirrhosis. Is there going to be necessity to monitor fibrosis stages, either non-invasively, with blood or with fibro scans?
I think that one of the utilities, theoretically, for fibroscans would be after you have achieved an SVR to periodically monitor your patient and see when they do or do not need to be continued with HCC surveillance if they're cirrhotic. Because if the fibrosis regresses, then perhaps we don't need to.
Other comments?
It's a research question.
Okay. We heard about special populations, we had a lot of comments. Our attention was directed to the underserved, the people who might be harboring a reservoir of infection, those who are current IV drug users. What other special populations are out there that we need to approach? We heard about co-infection, peri-transplant. Some even brought up the notion of women of childbearing age in an effort to prevent infection. What are your thoughts about where those people fit into our outreach? Maybe from a public health perspective, down at the end of the table, Mitch. Is there some reason you're apart? We'll have to move you down.
I just was obedient. I comments from me, but my name was here, so I sat here. I think we have gotten the major subpopulations. I'll take it to give something that I've been thinking of when you're talking about side populations, and especially when we're talking about, the analogy when I give you the bottle of pills, this is a Tesla. That strikes me as a very good analogy for a middle-class person. What I was imagining is if I were giving it to one of my patients, them thinking how much more I could change their life by giving them a $40,000 voucher to food, clothing, a stable place to live. And the hardest part of this, in all of this, we so much, all the people in the room, I feel, want to be patient-centered. But of course, what patients want is very heterogeneous. And I take care of many people for whom eradicating their hepatitis C is really important to them. And I take care of many people who have hepatitis C where it's not even on their top 10 list of things that matter to them at that moment. And I was trying to figure out how, you put that together with, this morning's discussion, which is a much more technical, discussion of the finances and the issues, but if we want to be patient-centered, I'm not sure how I reconcile that.
Peggy, you have huge experience not only in your ecclesiastical counseling, but in your counseling as the head of a hepatitis C support group. And in our prior meetings, you told us a rich set of stories about patients you've encountered and their top 10 list and how hepatitis C treatment or going through treatment or paying for treatment has impacted them. Could you share some of that?
Well, my response would be, as a nurse, which is that this is an infectious epidemic. And whether it's on their top 10 list or not, people need to be treated so they're not spreading it. And that's a big factor. It makes it different than some other diseases, that there'll be a large number of people that need to be treated initially, and in fact, it could be essentially eradicated in this country, and then there would not be as many from that point on. And so cost could be a long-term contract in that case.
Say more.
Well, that there would be a lot of people treated at the beginning, but maybe not all of the cost happened at the beginning. Maybe it was to pharmaceutical companies, or however this gets worked out. The cost could be spread over a long period of time, because the impact immediately will be huge, but it won't be in the long term if we treat everybody.
So we're taking that as a note for Roundtable 2 to see how we might change contracting mechanisms. You also said you had a couple of stories of how cost, the co-insurance, the co-pays impacted individuals going for therapy. And, per Mitch's comment, is that where they would have wanted that money to go?
Well, I know I'm selling my house because I went on treatment.
Oh.
So there is big impact to people's lives. And I think it's not solely about that person. There's a larger consideration. And I know a lot of people that have serious serious health and financial impact from having hepatitis. As I said earlier, that I really had to leave both of my jobs and my careers. And so at the same time that I'm incurring expenses because of hepatitis and treatment, I have lost employment. So there's big impact.
Bill, you have a comment?
A couple comments. One I'll comment on that is, it's every pharmaceutical company, and it's not just Gilead, has patient assistance programs. And I would advise those who can't afford it to always go to those patient assistance programs to see if you can get either free drug or copay cards, or even contact foundations. There are multiple foundations out there who can help you with those donut holes or those copay cards. And again, I'm not the expert on cost, but I do, and I'm aware of those that are at almost every company. So I think that makes access not the problem. But I did want to comment on your other thing about unmet needs. Is I think women of childbearing potential are probably the biggest area of unmet need that has not been addressed, that has not been studied, because ribavirin has been a part of the regimen, which has a category X. So it's never been broached to even think about it. But now with coming up with the sofosbuvir and other regimens that will come that do not have ribavirin in there, you may see the potential to study that. So we don't have the answer, but at least there is the potential to study that if you have a category B designation. And so that's an unmet need that should be studied.
Yeah. Mark?
Yeah, Bill, I wanted to ask, you mentioned the patient assistance program that pharmaceutical companies have, and I know they've had them for a long time and well used. Have you ever thought about expanding them beyond the individual patient to, say, someone like Mitch's LA Department of Health Care, to public sector programs who clearly cannot afford to provide this to all the people who need it? It doesn't seem to me there's much of a leap from the individual who can't afford it to a public sector program that can't afford it.
That then would be our commercial contracting department. So yes, there are departments that, again, every company that would look at doing those types of contracts. Yeah.
So
again, not my expertise though, but yes, that happens.
Right. So we do have somebody with a little more of that expertise in our roundtable too, and we'll address that. But let's ask Neil. I mean, you're the doctor for all of the people enrolled in California Medi-Cal. You have to approach this issue of contracting, looking at individual ability to access the medication even after you're contracting. How is this actually playing out, either with sofosbuvir alone or now the combination product?
Well, I think the challenge across the system, and certainly in Medi-Cal, is that the evidence base, the practice, how the drugs are being used is constantly changing. In a week or two or three, we should have updated clinical guidelines from the VA health system and from American Society to Study Liver Diseases /IDSA. And so the guidelines, which only came out not that long ago, are already in update and probably will be updated again in 2015 as new medications come out. So the current challenge is to try and, for a large population, over 11 million Californians are on Medi-Cal out of a population of about 38 million or so. So approaching 1/3 of Californians are on Medi-Cal, is to provide the best value on behalf of, first of all, members, and then on behalf of taxpayers. People need to be thinking about, we talked about it a little bit in the morning, about how it came out in the public comments. This is a broader issue of funding, and usually healthcare isn't thought about that. People go in and they assume they'll get treated with things that are cost effective, but they're not thinking, what if there was a 5% increase in costs? Will we accept that? Medi-Cal is a big part of the state budget. So is corrections, so is higher and secondary education. And if people just think, well, why don't we just pay it? And then where is it going to be moved out of? Higher education, secondary education, prisons, which bucket? I don't think, at least reading the polls, that a whole lot of people say we should just increase taxes. I don't think that'll probably happen. So it's become an issue that all of a sudden choosing wisely comes to, are we doing across the healthcare system, doing the best with the budget that we have? for those, many in this room are familiar with the Oregon Medicaid system, which has a waiver and actually ranks with an independent body, much like this actually, in legislation, ranks things from 1 to down to several hundred in order: dental services, coronary artery bypass surgery, hepatitis C treatment. And then the legislature funds to the level that they believe the budget can fund in order: 1, 2, 3, 4, et cetera. I haven't seen other states adopt that. I don't think other states have tried to. It was 15 years of quite a bit of turmoil. But anyway, it's a long story of how I think it's raising up much broader issues. It's not really just about hepatitis C treatment. It's what about the next breakthrough drug, and about really not just healthcare policy wonks talking about value in the system, but the residents of California and the United States thinking about the value of healthcare in a much more explicit way. This has been, as I said, in academic and policy circles and in groups like this, but now it really is about the state budget.
Right. I had a comment during lunch that people should have reacted perhaps to price when some new HIV drugs came out over the last couple of years that were very expensive. But at this point, because of the magnitude of the population, numbers with B's on them start coming out, and that has certainly gotten people's attention, whether it should have been raised before. I want to ask again, Peggy made the point very persuasively in her comments and some of the other public comments that IV drug abusers should be treated. I mean, I want to remember that treatment for IV drug abuse involves more than treating for a viral infection. It involves access and participation to opioid abuse treatment programs. And I want to ask again, Mitch and Neil, a little bit from the public perspective about how we're melding these needs, these medical needs for patients. And then we're going to go and turn to Jim a little bit and hear about it from the commercial insurer side. So, Mitch?
Well, I don't believe in absolute exclusion. So, there'd be no basis to say that active injection drug users should not be treated, because there's no basis for that. I think, again, it is reasonable to say in any system who is most likely to benefit treatment. With an injection drug user, my question would not be, are they using drugs? My question is, would their life allow them to take a pill reliably daily, right? Because it would not seem that they'd be a great candidate while they're using the medicine, while they're actively shooting. I'd also, as a system person, want to know, would that be the most patient-centered thing they need at that moment? Or is what they need at that moment methadone or substance treatment? Is that the number one thing? And I think it's easy to be seduced by the medical technology without recognizing that people's lives are often better improved by things like housing, social support, connection to people they love, and that as well. I think from our point of, as a practical matter, we're not going to exclude anyone, but we're going to try to treat those people who represent the best candidates for treatment at that moment. And it's hard for me to see, since no system is capable of treating everybody instantaneously, that seems the logical approach.
Thanks.
I would say that our current guidelines are in alignment with what Mitch described. It said basically they're trying to be supportive of the patient to ensure that they're able to adhere. We heard about adherence. It's not perfect, even with a good side effect profile. I think the challenging thing is when we say the person, if they're active, need to be in treatment, whether it's alcohol or IV drug abuse, need to be in a stabilized environment is kind of what we're talking about. But as Mitch said, it's not just relative to IV drug abuse or alcohol abuse and the need for stability, but it's in the context of, because people will say, well, there's not enough drug abuse treatment, and there's not enough mental health treatment, and I would agree. And then I would say, but there's not enough housing, there's not enough food delivery, food insecurity is not happening either. And so to kind of point out and say, one limitation in the system, the difficulty in the public sector is that we're trying to deal with multiple needs, including the specific medical needs that we're talking about here in hepatitis C, but there is a broader context to help and support the patient, social support, housing, so they're able to continue a regimen that takes a number of weeks.
Marge, could you remind us of the tagline for your organization? It's particularly relevant.
When there are no easy answers, which is our work focuses on bringing the public's voice into complex health policy decisions, all of which are ones for which all answers, all possible options have their pros and cons, and then trying to understand where the tension is. The tension here, I think, has been pretty clearly laid out, and it's how does one allocate resources in a fair and equitable way. If I were presenting this to the public, and I will just sort of throw this out, and the public forgive me for speaking for them, as many of you know, when you ask people to respond as what we call citizens, they're making social decisions for everyone, and that includes themselves. People have a strong belief in personal responsibility. I mean, that theme is there all the time. So if an average lay person were truly around the table, they would say, give it first to those who are going to die without it. That's priority number one. But the idea of continuing to provide treatment for those who may go out and become reinfected is very problematic for the public. So I'm here just to report what I think the general public would say to a lot of these issues. And of course, they're very torn about the cost of drugs. They want these costs to come down short of government intervention. So market pressure, plead to their sense of the common good, but let's get all of the stakeholders on the same path together.
Well, Marge, to that point, in our second panel, we have an economist. So we're going to talk about the market and how well that works. But now I want to come back to Citizen Kylie. So, Neil's got a tough issue. The state budget is a zero-sum game, sometimes less than zero, depending on how the economy is doing. And it's pretty scrutinized, and he does have to deal with these trade-offs between many, many different kinds of social goods. In some ways, your job on the Medical Policy Committee for your health plan is more circumscribed. You're dealing within the realm of health services and covered medical benefits. How do you approach this kind of situation where we may need to prioritize simply on the basis of pragmatism because not everybody can be treated, and because you have a budget and, people are supposed to keep to their yearly budgets?
Our philosophy at Blue Shield is we have a mandate to provide affordable care, high-quality affordable care. And so in situations of medical policy, this comes up all the time. In this case, it's not so much a medical policy issue. It's pretty much a slam dunk. It works. It's fairly easy to prescribe. And so it's simply a pricing issue. And we have a lot of, we have a mandate to keep our premiums down. This is in the press all the time. And so that's our pressure at this point. That's our pressure from our members to keep premiums down, and from our contractors. And so I've seen a huge explosion in costs. We've spent over $100 million in the last year just on these drugs for a very, very small percent of our 3.5 million members. We would prefer to treat everyone. That would be our goal, and we do that with many other diseases, including HIV. We don't require any prior authorization. So our problem, of course, is with this unrestrained pricing, non-transparent pricing, that is, I think, affecting the ability of our company to provide quality health care to our members. We're having to prioritize, and in this case, we're having to potentially make choices about who gets treated and who doesn't, when we don't like doing that.
How organized is the thinking in any of the health systems represented, or those you're familiar with if you're not directly in one, to that conscious prioritization, sequencing, outreach? Or is it sort of, if the person is demanding, they're going to get treated whether they would fall into your highest priority group, the ones who are going to die without it, or not?
Well,
There's no question that people who assertively want treatment are going to get treatment more likely, and I'm not sure that's such a bad thing. Again, because there are pluses and minuses, and it does, while it's a more tolerable regimen, it is with side effects, and some of this could be unknown. It's still new treatment. So there's no question that in our system, the people who, assertively want to get treatment, we're going to, more aggressively treat them than people who don't find hepatitis C to be a major problem. I do believe that those people who that we heard about, who are stage 3 and 4, who might benefit from treatment sooner than later, would be a good target. I cannot say I run a system yet that is yet good enough to be able to be actively identifying people who are not coming forward, who are not being referred by their doctors, and be assertively getting them into a very expensive treatment. But
other comments?
Goal.
You have to have a very organized healthcare system in order to target a population, let alone a subgroup of that population. So whether it's, diabetes and targeting people who have uncontrolled diabetes, that may be what we most want to do. That you would say, well, the logical thing is to find people who have the most, poorly controlled diabetes and get them in and get them on the most aggressive treatment. But having a system that is really set up to be able to do that is really a whole other topic. But in an ideal world, I think if you had a system where you could say, here's my list of all of my hepatitis C patients, here's what I know about their fibrosis stage or maybe their platelet count, and that's how I'm going to identify my most advanced patients and target those, I think that would be ideal. But since most systems are not that well designed, I completely agree with Mitch. I mean, in part, it's going to be the patients who are banging on your door the hardest. They are also going to be very motivated patients and very compliant patients.
Joanna, you live in the closest thing we have on Earth to an ideal healthcare system. What kinds of lists do you get?
No, that was a setup. So what we've done in Northern California is we first decided that one goal is to treat the people that need to be treated, get rid of the virus, but that's really just one part of the Hep C. They need to be evaluated for the entire package. Are they cirrhotic? If they're not cirrhotic, how much fibrosis? If they are cirrhotic, when was their last HCC screening? What is their MELD score? Should they be referred for a transplant? If you do want to treat them, you need to know if they're a transplant candidate. You want to make sure they're negative for 30 days going into transplant, because per the Colorado data, then those people are cured after transplant. So there's lots of pieces to the puzzle. And what we have done is for Northern California, we've identified 17,000 members who have Hep C. And then we parsed them out to people that we know are cirrhotic on biopsy, or nodular CAT scan, a spleen the size of Michigan, whatever. And those people that may have fibrosis, those people that have no evidence of synthetic function but are viremic, and a large number of people who actually are ELISA positive, but no one's bothered to check a viral load to see if they're even virus positive. So and what we've done as the first step before we try to treat everybody is we gave every medical center a list of their medical numbers, and then their care team is going through every chart to see who has what and segment them out so that we can outreach to the people that need to be outreached to first. But again, if a physician has a patient they're worried about, they send them anyway. If someone has Hep C and they want to be treated or they want to be evaluated, then we just see them as they come in also.
Thank you. In your experience talking to clinicians and healthcare systems about these antivirals, what kinds of organization have you seen as opposed to just ad hoc, random sorts of treatment? And I'm talking to Bill and Juan Carlos.
I'll speak to, again, I'll look at the cohorts that have been published, the TRIO and target cohorts, where it's about 4,000 patients. And, In both of them, they're very similar. About 48% were cirrhotic. And that means 52% were non-cirrhotic. And so it was about a mix of 50-50. And for the non-cirrhotics, it ranged anywhere from F0 to F3. And who got treated, when I would ask many of the clinicians, it was very much what was just said. It was the motivated patient who wanted to get treated, who they thought would adhere and had the best chance for a cure.
I totally agree with that, absolutely.
Peggy, in your discussions with all the people who've come through your hepatitis C support groups, how did they come to attention and end up getting treated? What is the route that you've seen?
How were they identified?
Yeah, use the mic.
Oh, sorry. Some of them were identified by accident on lab work. A lot of them felt like they had symptoms that their friends had. Some of them were IV drug users or former IV drug users, and they went to get tested. And there are just a lot of routes for coming into the support group. What I wanted to say is that the damage is not just to that person. I keep saying this, but the families are just wrecked by this. When you have F1-2, you look like you're malingering, you know, and are accused of it. Yeah. Families split up from this. You know, the community costs are high. You know, so anyhow, these people did come into support. They sometimes their partner brings them in. It's like, we're coming to this group. I don't know if I want to get treated. But that's how people come.
That's a powerful and evocative word. Go ahead, Meg.
I'd like to hear more if anyone has any data about the IV drug users, because the question about, clearly if you can eradicate it, it's a population at risk for spreading it. But I'm concerned about the idea of reinfection even while they're on treatment. I don't know if there is much data about this, but I can see why there might be a rationale for saying, as Mitch actually has pointed out and others, first treat the substance abuse or the injection drug use, however you can do that. Does anyone have any comments about that? Because I know that there's a political will on the part of those who advocate for these folks to get them in treatment. But I want to understand more about the clinical aspects of that and whether we're going to be throwing away $85K on someone who's going to get reinfected or not clear.
Well, my understanding, but I'll defer to people who study. My assumption is if you're shooting, you're going to get reinfected, right? There's nothing about the treatment. So I'm assuming you've taken the treatment, you've been treated. So do you have what we would call immunity to when you're exposed again?
It's not immunity, but the reinfection rate is very low.
But do you mean narrow? I'm sure among 1,000 people you treat, it's very low. What I'm wondering is, in people who are actively shooting, which are a very small number of the people we've actually treated,
right?
Why would it be low?
I don't think it's known why it's low. I actually looked this up right before this meeting to get some good numbers on this. So in very high-risk groups, so HIV positive, MSM, who are practicing high-risk behaviors, active injection drug users, patients in corrections who have been either treated or spontaneously cleared, who are continuing the high-risk behavior, the rate of reinfection is between 5 to 12 cases per 100 person years.
Per 100 person years. So 100 people in a year. 5 to 12, but that's not so low. 5 to 12 people out of.
But everyone is continuing their high-risk behavior, and everyone had Hep C. So these are patients who have either been successfully treated or had spontaneously cleared and continued their high-risk behavior. So I think it's lower than, there's a lower rate than would happen in the community if you had never had it and then had been, in cohorts of injection drug users, in somewhere 90%. Like Stanford, it's 90%.
But
right.
that is as a prevalence. I don't know what it would be as a annual incidence, but you're absolutely right. 90% is a prevalence of active, young, drug users,
right.
Urban.
Okay, so clearly some more epidemiological investigation is going to be required for this particular group.
And and continued studies, because it's not just treating the patient, it's looking at, because we've looked at this too, it's looking at the cohort of who they're injecting drugs with.
Yeah.
And it's almost like support groups. It's if you're under treatment as an IV drug user and you're getting treated and you're cured, it's bringing your friends you're injecting with, because they're probably also hepatitis C infected. So you either do one of two things. Either you change the behavior where they stop having that high-risk behavior, which is preferred, or two, you then find their whole cohort of people who they inject with and try to cure them, so that then, even if they continue to inject drugs, but they're injecting drugs with those who don't have Hep C, the chance of reinfection is zero if you're injecting drugs with nobody with Hep C.
So even if we don't have Joanna's incredible systems that give her lists of patients, perhaps we can use Facebook.
But that actually has been done, and there's a research project that has used Facebook, that has used cell phones, that finds these networks of who you were friends with to find out those networks. Yes, so that has been done.
Yeah, and there's been a cohort at UCSF that's been followed for many years of young injection drug users, and the researchers will meet them at 7-Eleven and track them.
One more comment, then I'm going to go on. Go on,
Okay.
Peggy, and then Juan Carlos.
Along these same lines of support, we have noticed that a lot of providers don't have a system of walking with somebody while they're on treatment, and that would be a valuable thing to do. And if the provider had a resource book or something else where people could get support, or if they had a person who called them regularly or met with them regularly, somebody already on staff, I think compliance would be much better.
Sounds like excellent suggestions. Some may have noticed that, Juan Carlos, go one more
Yes,
comment.
very quickly, Chet. I think it's very important to differentiate between what is the prevalence of infection, as we mentioned before, which is high among the IVDUs, versus the current risk of infection today, because the measures, the drugs, and the quality of life has changed. And that's why the infection today is lower. So just natural history for that has decreased dramatically, and for good, right? The other thing that is important is the encouraging news, and we have data coming from the 3D, is that if an intravenous drug user is under a methadone clinic, so he's behaving, and he or she is treated with a potent combination therapy, has the same chances to get cured that a patient who is not or doesn't have this kind of risk behavior pattern. And I think this is very encouraging for the patient.
That is very encouraging. Jim, just a quick question. You deal with lots of different physician groups all around the state. Have you seen evidence of organized, systematic approaches to identification and prioritization?
No, we've made a decision at this point not to do that. We're leaving that up to the providers. As one step removed, we feel like that's a provider issue and not so much an insurance company issue. So we do not make that a prerequisite to authorization.
I'm going to get a little tough on a couple of people on our panel, if that's okay, because we asked some very pointed questions earlier and got general responses. So I'm going to ask people on the panel, what have you had to do this year in order to accommodate the perhaps unexpected and large drug budget increases that you've seen in public programs, private situations, government healthcare systems? Let's get down to it. What have you had to do?
Well, it's hard to describe across the system all the things that have had to be done because obviously within, well, let me just give background. Some people may not be aware, but essentially all full Medi-Cal members that receive full scope Medi-Cal are all in managed healthcare plans. And so there is a so-called kick payment, a small subsidy to help deal with the immediate increase in costs because, as Jim noted, the costs were dramatic and rapid and not built in, obviously, to the existing capitation rate. So that's just dealing with the immediate dollars. But obviously, as I alluded to, Medi-Cal is not as part of the state budget. So without going into the details, as the budget process works through the administration, through the legislature, you can bet that there's a lot of attention in state government about the overall piece and how is this going to be paid for. I don't know that the answers have been sorted out. But at the health plan level, I think because we are in a fully capitated system, of course, we still have members in a fee-for-service basis. A lot of that is trying to work with the health plans to try and say, well, how do we maintain the other demands to improve quality, all the other conditions that need attention. And there is, I don't know how to describe it, but a lot of concern about meeting responsibilities of health, as Jim said. Each health plan is trying to do everything is needed to optimize health for each member while dealing with a sudden and really unanticipated increase in the budget. And so going forward, as these new guidelines come out and we start to see what further fiscal implications, I certainly think both at the state level and the plan level, it's what you raised, Jed, which is what are you going to cut back on? Can we really start taking putting into practice the Choosing Wisely program, which has outlined a lot of areas where there's overuse? They've been identified, but in terms of actually getting to the action level, I would say we aren't there yet. And I think it is forcing that conversation when you have a report that says premiums may go up 5% or the capitation rate may have to go up 5%. And when 1% was that trigger threshold, like we need to be concerned, it's 5 times that. I think this is generating a conversation. So I can't say what has been done except the kick payment was instituted as an immediate means of trying to deal with the fiscal demands that the new drugs placed on the system.
And 2015 budgets?
Well, that's that's looking what's happening in the next few weeks on what pricing looks like. Prevalence, refined estimates, more data on what happens with longer-term treatment. It's a literally right now issue.
Jim.
So we're addressing things at 2 levels. The first is a macro level, which would be to try to develop coalitions with other insurers to negotiate with companies, get a better bargaining position in terms of negotiating clout. That's would be our number 1 priority, to reduce the costs, and then we wouldn't have to have the constraints that we placed on the micro level. On the micro level, what we do is we evaluate every patient. So the pharmacy team looks at them on a daily basis to make sure that they meet criteria. We've developed criteria, so F3 and above right now is our criteria, or anybody that has comorbidities. So comorbidities are evaluated on a case-by-case basis by the physician that's in charge of that. And so we try to be liberal in that regard, but it does come down to a judgment call. And so those are basically our way of handling that.
Thanks, Jim. Those are difficult jobs to do. Go ahead, Neil.
I want to echo, although I've focused on the clinical and the policy and the budget, obviously the department and administration is working on the negotiated prices that was alluded to this morning that Medicaid programs work on, and there'll be more. I know in the second panel, my colleague Matt Salo is here from NAMD, so more on that.
Very good.
One last comment, of course, is that as we've seen major changes just in with the introduction of Harvoni with Samipravir dropping off, significantly has reduced our costs, and so we're hoping very much that some of the new drugs, when they come online, will help us with that.
Intriguing. I'm going to ask our panel to see if there are any residual questions they have before I get to a somewhat technical question that I want to ask to conclude. So, Paul?
I'm just wondering if there's any information from other countries, maybe who are similar in terms of GDP per capita, and how they're prioritizing patients. Does anyone have any information on that?
Bill or Juan Carlos?
Exactly. They are doing the same thing, same approach in the European community than in the U.S. So far, they are prioritizing F3s, F4 the same way than here.
Even though they're paying much less, I believe, for the drug. They're still having the same criteria.
Mm-hmm.
They pay a similar government price. So their government price is similar to the government price here in the United States.
Oh, it is?
If not higher.
Huh.
We'll return to that point in our next panel. Any other questions from this panel? Well, Dan.
I just wanted to ask Dr. Fox, she implied in one of her earlier responses that maybe in the F3, F4 group, if they are SVR, that there is a regression of fibrosis. Is there serial biopsy evidence of regression? That intrigues me, because then it would give some justification to maybe waiting until they have higher degrees of fibrosis with the optimistic view that some of this will reverse. What are the data on this?
There have been some studies that after SVR, and this is also from the PEG-RIBA data, probably more from the PEG-RIBA data than from the DAA data because there's been more time, of patients who've had serial biopsies after treatment. And it's certainly not 100%, but there are good data that show that there's regression histologically. And then there's observational data of patients over time that show that, you know, even if you're starting off at F4 or at lower fibrosis levels, that over time you have decreased rates of developing cirrhosis if you didn't already have it, or if you already had cirrhosis, decreased rates of decompensation, decreased rates of developing liver cancer, HCC, and decreased rates of a liver-related death. So an SVR in cirrhotics, yes, there's data that some patients histologically regress, and then there's observational data that they have better clinical outcomes.
So there are several studies, but mostly, as Rina mentioned, with PEG interferon-based therapy, although SVR is SVR no matter what.
Is that just a reportable case, or is this 10% or a quarter of the patients? Any idea?
There is this study, for instance, for the University of Colorado that I think Jet alluded before. Even from 100 patients who were in the waiting list for liver transplant, 20% of them who achieved SVR actually they were removed from the waiting list for liver transplant.
That's interesting.
And the ones who were negative and went to liver transplant, actually none of them recurred the disease post-liver transplant.
Very interesting. Thank you.
May I ask a clarification of the question we're talking about?
Yeah, in the mic, please.
A little confused. I thought what we were mostly saying and what the rules were mostly reflecting about treating groups 3, 4, and those with comorbidity is not necessarily that it's better to treat them. It's better to treat them first if the systems have limited capacity to treat. Mm-hmm. But I'm wondering if other people have that same, because sometimes it sounds like implicit in your question I was hearing, well, maybe it's okay to wait because the fibrosis will regress, which again, I support and think it's good, but it's only because if we could magically treat everybody immediately, it doesn't seem that the evidence supports treating only people with 3rd, 4, or comorbidity. It's just that there's no way our systems can do that. Even if money weren't an issue, there's no way our systems could do it. There's just not enough infrastructure. We don't know who everybody is to treat.
I was just suggesting that given the constraints, it gives a little comfort to know that there is regression, even though you're forced into a system that you wouldn't like to be in, but you seem to be constrained. That was my point.
So my last question relates to... go ahead, Bob.
Just give me one little thing here. This is an interesting thing that comes up occasionally, and particularly where patient advocates are really involved in activism, actually goes right to this particular thing. On the expert call that we had leading up to this, there was a comment made, and I've heard these comments numerous times and these kind of groupings of people together, and I don't mean to imply that it was ill-intended or anything like that, but the comment alluded to effectively, is there good disease or bad disease? In other words, is the worst stuff really bad and the not so bad stuff kind of a good form of the disease? And a disease is a disease. Whoever's got Hep C has Hep C, and they want to get rid of it right now. So this is the problem when you start talking about the Fs and stratifying people here.
Thank you, Bob. You have support for that position. I want to ask one more question, which is technical but important on how it impacts patients. And that's related to formulary tiering and design, and whether these kinds of drugs are specialty drugs and how that impacts where they're placed in formularies, commercial, Medi-Cal, Medicare Part D, and how that then impacts patients' financial responsibility. Joanna, you said something about, 20 different copay benefit designs. How does that play out? What are the considerations here that we should also be aware of?
Well, what we do is either the clinical pharmacist or the nurse will sit down and figure out what their copay is going to be, and then give them data on resources that they can avail themselves if they're going to have a substantial amount of money that's going to have to come out of pocket. But the other is, as I had alluded to with the Medicare patients, we specifically sit down and go over a list of all their medications, figure out when they're going to hit the donut hole, and make sure that when they're treated, since it's just for 12 weeks, if you time it wrong, they're going to go through that donut hole twice, and that will really increase the amount of money they're going to have to spend. So you have to time it right.
Can you just put in perspective what the range is of that copays?
Okay, help me, Rena. It's, you go up to, what is it to get to the donut hole? It's 3,000 or so? Yeah, and then the donut hole is 4,500, and then so you have an X amount of copay depending upon what kind of insurance you've got, and then you hit the donut hole and you pay 4,500, so it's full price. But for these drugs, that's 4 days, you know. So then at the end you're paid. It's 100% paid for the rest of the year. So it's just that, you know, there's a real constraint. The last quarter of the year, you don't want to start someone because theoretically they'll be halfway through, and then January 1, it resets, and they're going to have to go through it again.
That was an elegant explanation of a very complicated issue. Jim, you said that the medical policy aspect of these drugs was easy, because they work. What about the pharmacy construction benefit considerations? Any insights there?
The pharmacy constraints are, we put these are specialty drugs, we put them on the highest copay, and while we don't like to do that, the cost of these drugs, we feel, shouldn't be entirely masked from our members either. And so to some extent, they are, because they're paying $100 or $150 copay with each prescription refill, and they're only going to get those 1 or 2 prescription refills. So while it may seem high to them compared to their $3 for generics, it's nothing compared to what our costs are. So we do think that we shouldn't necessarily shield our members from some of the costs that we're seeing.
Marge.
So you raised the issue of specialty. This falls in the category of a specialty drug, and I know the definition of specialty drug is kind of loose at the moment. Since it's not an injectable anymore, people can take an oral pill, they can take it by themselves, so that's sort of one criterion that no longer applies. So is the only thing that now defines it as a specialty drug is its cost? And is that a good enough justification to keep it as a specialty drug?
Well, it's a good question. I don't have the perfect answer for that, but yes, at this point, cost is certainly is the constraint.
Fortunately, we have a variety of health policy experts coming in another 10 minutes to our next panel who will explain the market arrangements for pricing of pharmaceuticals and the regulatory apparatus that gets them to the patients who need them. But with that, can we thank our first roundtable participants? Okay.